The topic is necrotizing ulcerative periodontitis. Now, as the term indicates, it is a necrotizing form of a disease, or it's a degenerative form of a disease wherein there is necrosis of the periodontium or the periodontal structures. If we can introduce the topic of necrotizing ulcerative periodontitis, now it is basically a continuation of your necrotizing ulcerative gingivitis. When this necrotizing ulcerative gingivitis progresses to involve your other periodontal structures, or it involves your attachment apparatus, then it leads to what is called as your necrotizing ulcerative periodontitis. And in 1986, this necrotizing ulcerative gingivitis, or it was categorized, or it was termed as necrotizing ulcerative gingivo-periodontitis. It was in 1989 that the World Workshop termed this as necrotizing ulcerative periodontitis. So they have given a special category for the in the classification system for the necrotizing ulcerative periodontitis. But in 1999, this necrotizing according to the 1999 classification, this necrotizing ulcerative periodontal diseases were subclassified under periodontitis as a manifestation of systemic disease. See the clinical features. Basically, it is similar to your necrotizing ulcerative gingivitis, wherein there is there is involvement of your gingiva, especially your interdental papilla, with necrosis and ulceration. Okay, so it starts basically at the coronal end, or the coronal portion of your interdental papilla, with basic necrosis and ulceration, and then this slowly progresses, or this spreads to your gingival margin, and then it can spread further to your attached gingiva and then into your underlying periodontium. Then usually this condition is very painful because there's necrosis. The tissue is becoming dead, okay, and it's forming an ulcer. So you can imagine the amount of pain that the patient might have. And then there is a bright red marginal gingiva because it's a kind of an acute form of a disease, and the gingiva just bleeds very easily. Just with touch, it can bleed. The very distinguishing feature of ANUP, that is your necrotizing ulcerative periodontitis, with that of your necrotizing ulcerative gingivitis, is the spread of the disease to involve your periodontal tissues, leading to a destructive progression of attachment loss and bone loss. Okay, now here in necrotizing ulcerative periodontal diseases, you find what is called as a deep interdental craters in your interdental, or they are the typical lesions of your necrotizing ulcerative periodontitis with an interdental crater formation. In this form of a disease, the main important feature is you don't find the pockets, means you don't have any pocket depth as you see in a conventional periodontal or conventional periodontal diseases like your chronic or your aggressive periodontitis. You have periodontal pockets, but whereas in your necrotizing ulcerative periodontitis, you don't have periodontal pockets. The main reason is the entire tissue is getting necrosed there, so there is no kind of vital cells which are present for the junctional epithelium to migrate apically to form a pocket. So whatever the tissues are involved in that area with necrotizing ulcerative periodontal diseases are getting necrosed. So there is no tissue left for the tissue to migrate apically and cause a periodontal pocket. Whereas if you see in your chronic periodontitis or any aggressive form of periodontitis, you have a conventional pocket probes, or pocket periodontal probing can be done to detect your periodontal pockets, because your junctional epithelium has vital cells and the cells are migrating apically and leading to a deepening of the sulcus, therefore a pathological deepening of the sulcus leading to a periodontal pocket. So that's the main difference. Now, in cases of advanced lesions of your NUP, it may lead to severe bone loss and tooth mobility, and one fine day a tooth loss. Then apart from that, these patients also can complain of a malodor because there's necrosis happening in the tissues and there's ulcers. The patient is not able to maintain the hygiene because of the painful condition. He's not able to eat. So all these factors can cause oral malodor. They can show some systemic symptoms and signs like malaise and fever, and then regional lymphadenopathy. This is a picture, or the clinical picture, which shows you the necrosis of the interdental papilla and your marginal gingiva leading to a gingival recession, okay, and interproximal attachment and bone loss. Now, what are the microscopic findings? Now, if you take the tissues under the microscope, what all you see? First thing, you see a mixed microbial flora, and just underneath this mixed microbial flora, you have a subsurface flora, typically of your spirochetes. So this dense aggregations of spirochetes or the bacterial zone. Apart from that, just below the bacterial layer, you have a rich layer of your neutrophils. Okay, there is a dense aggregation of your PMNs, that is a polymorphonuclear neutrophils, forming a neutrophil-rich zone. And then below this, you have a layer of necrotic cells. Okay, so you can call this layer as a necrotic zone. The microscopic features of NUP also have high levels of your opportunistic bacteria or opportunistic protozoa or viruses or yeasts or this or fungi, which is indicative that this infection is supposed to be it's most common in an immunocompromised host, and then because of the growing of these other pathogenic microorganisms, you can say that the patient is more prone for opportunistic infections. What is the main etiology for this NUP, that is your necrotizing ulcerative periodontitis? It's not been typically determined what would be the etiology for your NUP, but then they say there is a mixed fusospirochetal. It's basically, they say that it's a mixed fusospirochetal infection, or the bacterial, these fusospirochetes play an important role or a key role in development of your necrotizing ulcerative gingivitis, which further progresses to your necrotizing ulcerative periodontal diseases. But then you can't say that these bacteria are the ones which are solely responsible for causing this disease. There are some predisposing factors which predispose the individual to develop the disease. Now, what are these predisposing factors? Patient's poor oral hygiene. If the patient is not maintaining with an immunocompromised situation in the host, they can make the patient more prone to develop this necrotizing form of ulcerative periodontal diseases. Apart from that, already a pre-existing periodontal disease can contribute to this development of your NUP. Apart from that, smoking. Again, smoking can be a factor for causing or predisposing the patient to develop your necrotizing ulcerative form of diseases. And then other viral infections, which again compromise the host defense mechanisms, and other immunocompromised situations, like patient is infected with HIV, he is HIV positive. So these patients usually have all HIV patients or AIDS patients do have the main important feature of NUP. Then psychological stress. Let's see how each one would predispose to NUP in the further slides, and then even malnutrition has been told as a predisposing factor. If you take psychological stress, now these patients usually, like patients with anxiety patients or high depression levels, all these, what do? Or patients who have great stressful events, or probably they have lost their close ones. And then what happens with stress? You know with stress that increased levels of cortisol is produced in the body. Now this cortisol will make the patients more susceptible to an immunocompromised situation, because it has a suppressive effect on your immune system. So once this cortisol is increased amounts is secreted as a result of stress, it causes a suppression of the immune response, and therefore leading or making the patient more predisposed to a condition of necrotizing ulcerative form of periodontal diseases. Now, malnutrition. How does malnutrition affect? Malnutrition will definitely diminish the host response. If the individual is not nourished properly with all the required balanced diet, then he can always suffer from a defense or a defects in the host defense system. Therefore, he gets more prone or he has high chances of developing any kind of a disease. Now, that would be the reason. Now, how does it affect the host immunity? Is it can affect the phagocytosis or the cell-mediated immunity, or it can have a role on the complement system, or even the antibody formation, and finally the cytokine production. If you see these AIDS patients or the HIV positive patients, how is it different between a HIV positive patient with NUP and HIV negative patient with NUP? There's not much difference between the two, that both these patients do develop the same kind of signs and symptoms, but then it is more severe in case of a patient with HIV positive developing an NUP rather than the one who HIV negative patients. See, the NUP lesions, if you see the slide, it's clearly explained. The NUP lesions in a HIV positive individual are more destructive when compared to the NUP lesions in a HIV negative individual. So if it is more destructive, definitely there's going to be more attachment loss and bone loss, okay, and then it happens at a very extremely rapid rate. What are the other, now it's also seen that this can you can get some complications because of the HIV positive status. Just your necrotizing ulcerative periodontitis can spread further to involve your vestibular areas and the other mucosal tissues in the oral cavity, and then further leading to what is called as necrotizing ulcerative gingivostomatitis. What are the microbial flora that commonly are seen? Mostly the cases, in case of NUP positive, you find most amount of Candida albicans and all the other microorganisms. So the presence of Candida is supposed to increase the chances of developing some opportunistic infections because the host immunity is compromised there. The NUP is more frequently seen with the diagnosis of AIDS. So whenever you diagnose the patient as having NUP, then you have to suspect the main etiology, maybe the patient is HIV positive. So that you should incorporate this diagnostic criteria into your when you consider diagnosing your NUP. How do you treat these patients? The first thing is, first identify what is the systemic pathology that the patient is having, and then take a good consent or send the patient to a good take a good consent from the physician, and then advise him some good oral hygiene measures, and first identify what is a cause or what is a systemic load that the patient is having, and then do a thorough medical evaluation, followed by which you have to incorporate what would be as a dentist, what would be your line of treatment is local debridement of the lesions, and then you can under local anesthesia. Please remember that these lesions are very painful, so you have to put the patient on local anesthesia and then only go about even the local debridement of the lesions, and then you do a thorough lavage. In order to get a good flushing effect, you can use your ultrasonics so that you can get a good flushing effects of the deep lesions, and then you put the patient or give the patient good oral hygiene instructions and put the patient on some antimicrobial adjuncts like chlorhexidine mouthwash in order to reduce the microbial load. Reduce the pain, you can probably put the patient on some analgesics, and then to supplement the systemic effects, you can put the patient on some antibiotics too. But you should always remember, when you're selecting an antibiotic, you should keep in mind that this patient is more prone for opportunistic infections, and more amounts of all these Candida species, yeast, protozoa, herpes and everything are more commonly found. So you should remember before you select a good antibiotic therapy for your patients. Probably you have to give an adjunctive antifungal therapy along with your antibiotic therapy in order to prevent the other infections that may develop because of the overuse of your antibiotics. Okay. Apart from that, you should make sure that the patients are maintaining a good oral hygiene, and then you can encourage these patients to regarding the importance of oral hygiene in order to reduce the extremely painful conditions. So that would be the final thing, that you have to take the patients. First, identifying the systemic underlying etiology is very important, and then always consider, I told you all even before, much before, that when you diagnose a patient with NUP, make sure that you always send the patient for HIV detection. Okay, that completes your necrotizing ulcerative periodontal diseases. Thank you.